morning, everyone. Welcome to day 2 of the Building Healthy, Strong Communities virtual conference. We are happy you have joined us for Centering Social Justice and Non-Public Behavioral Healthcare Part 2, Practice Strategies. Before we begin, I want to go over a few housekeeping notes. If you wish to receive CEs for today's webinar, you will need to stay for the duration of the event and respond to all the poll questions you see pop up throughout the presentation. You will see the first poll now. If you do not see the poll pop up, please place your response to the question in the chat. There will be time for Q&A during and at the end of the event, so please submit any questions you have either in the Q&A box or in the chat. We encourage participation in the chat throughout today's presentation. I am now going to turn it over to Sade Richardson, the Secretary of the School of Social Work's Alumni Board, to introduce today's presenter.
Good morning, everyone, and thank you for joining us today. It is my pleasure to introduce Dr. Daisha Price. Dr. Price is a clinical assistant professor of social work and the Diversity, Equity, and Inclusion program director at the University of Michigan School of Social Work. Prior to joining the faculty at Michigan, Price served as clinical practice improvement specialist in Wayne County with a focus on workforce development and implementation of evidence-based, best, and promising behavioral health practices. Price has gained clinical and macro practice experience in juvenile justice, community mental health, housing, schools, and foster care. As a mental health first aid and question, persuade, refer instructor, Price is committed to sharing her personal and professional experiences and knowledge to support others. Price engages with the community to disrupt and dismantle racism and oppression using a bioecological system and African-centered framework. As a professional, Dr. Price is committed to incorporating various strategies that will aid to the mission of reaching out, raising hope, and changing society. Dr. Price, thank you for presenting for us today. I'm now going to hand it over to you.
Thank you so much, Sade. I appreciate it. And I have to hear about myself twice in a row. That is so awesome. So once again, we have lots of alumni here. So welcome to alumni, retirees, all of the people who have agreed to join us today. I want to thank you for that. I did ask people to think about what made you join this session. I asked the same thing yesterday. And got some really, really great answers. And I did ask in the chat if there was anyone, I keep saying good morning. I'm like, is there anyone who is here that it's evening time for you? I just am wondering, is there anyone that's an afternoon, or we do have this 10:02? Okay, so thank you so much, Julie. Welcome back. And so glad to know that there are some people who are returning from yesterday. So today we're going to be focusing on practice strategies and for social justice oriented approaches in private practice. So our agenda today is looking at 3 things. One, first, just kind of reframing our roles and thinking about what that looks like. We want to talk about practice strategies as a clinician and as a manager, because I recognize that many of us might have different roles that we play within organizations or that we might want to play in different organizations. So we have 2 objectives that we want to make sure we accomplish in this next hour and a half together. One is thinking about the difference between public and private roles and expectations. We started talking about that a little bit yesterday, so we'll need to review some of that. And also want to make sure that people can identify at least 2 practice strategies that you could utilize as a private in a private setting practitioner. So those are some of the things that we want to start with. But before we go forward, there's some people that weren't here yesterday. So I would like to ask if there are some golden nuggets that people can share from yesterday. If you were here yesterday, what's a golden nugget? So Julie already put in examining centering justice and to continue moving forward. And so that's one of the reasons why she came back. But what's a golden nugget from yesterday that you could share for people who weren't here yesterday? So just something that you take away. That you took away, I like to call them golden nuggets. And if you could put that in the chat so others can see it, and I'll read them out as I can. All people should have access to the services they need. all people, even soccer moms or basketball moms or track moms or track dads or track people, parents, all people should have access to the services that they need. Thank you, Abigail. What are some other golden nuggets? We had a good time. Okay. All right. Alice said, ideal. Oh, here they come in. Social justice needs to be our framework. Ideal space will be where we have quality services. Remember, we want that better, that best, um, the bougie. We want the good type of service for everyone. Kelly, thank you for naming that. Even in spite of some of our best efforts, we may not be practicing with the lens of seeing social justice. We talked about using terminology, behavioral mental health, reframing the language of mental illness, and just talking about mental wellness. Um, we did come to realize how many mild to moderate folks are not receiving treatment even though they would benefit from it, and the need to have accessibility. Oh yes, correct services for correct needs readily available. Nancy, that almost sounds like a commercial. I feel like I need to correct services for correct needs readily available. I love that. Thinking about public services being responsible for things, anxiety and depression, like most likely not to receive help. So you all took a lot of things away from yesterday. So those of you who are just joining us, these are some of the things that we talked about. We talked about when we even think about different levels of care, we still want to think about how do we center justice and recognizing what our responsibilities are in those different ways. So thank you all for helping me to recap some of those things because we started with the foundation. So I do want to remind people that if it does feel like you're missing something, you might be missing the foundation piece where we talked about what it really means to center justice. I do believe those things will be available to people if you registered for them. So we welcome you all to reach out for those things. If you're like, oh, I feel like I'm missing something, I really want to review that topic or something, because our as you see, your colleagues in the chat are sharing some of the things that we talked about, and that was a foundation. So I want to thank you for sharing what your current kind of position and if you're alumni and things like that. But now I want to know how you identify as. And so there's another poll that's coming up, and I want to know, do you identify as a micro social worker, a meso social worker, a macro social worker, a generalist social worker, or does it depend on the day of the week? You even have that option. Now, I'll say for some of you all, it might depend on the time of day and the day of the week, as you have to switch back and forth and take the micro hat off or put the meso, macro. You're probably doing a lot of those things. So I'm going to give you a few moments. And if the chat is not working for you, please go ahead and put it in the chat. So I see macro social workers, recognizing public service providers. Some people are macro, micro, macro. So we have all of these different folks. And the majority of us have shared that it depends on the day of the week. So I'm going to share some micro and macro practice strategies. So to think about, what does it look like when you're working individually with a consumer or our client, or like when you're doing that direct interpersonal practice. But I'm also going to share some more macro level things. And if there are areas that you feel, I don't quite think this works with where I am, can you give me some ideas? That's where we want you to use the chat or the Q&A function so that we can make sure we answer those questions. So Nancy, you do employee assistance work. So, so direct services for sure. Thank you. And people are saying it depends on the day of the week. So 43% of us are saying it depends on the day of the week. So a lot of us are moving in and out of all of those spaces. And that's why it's important that we think about each part. So thank you for sharing that. So I wanted us to start by thinking about these different roles. And I know we have some retirees here. And so some people shared that they were retired, but didn't necessarily say where they were retired from. So I want us to think about, do we have people here that have worked in community mental health? I know yesterday we had people who are newer to the field and they work in community mental health. So if you work in community mental health and you have access to your chat, just put a CMH inside the chat. Just want to try to get a sense of how many people are in CMH. Okay, we got, okay, here you all come. Here you all come. So we are thinking about, so think about CMH. Now I want to hear how many people are currently in or have worked in schools. Just put schools in if you work in a school. I see some people are in CMH and in a school, which is fine. But if you're in schools, let's see that, because school social work is also a specific role and it looks different for different people. All right, so Catherine, thank you for putting in the higher ed. Now I want to hear, I already see someone put in veterans. So who has done or currently does medical social work? If you've worked in a hospital, if you worked in primary care, I want you all to put that in. Hospital, medical, oh yeah, emergency departments, primary care, okay, oncology, all of those different areas. Okay, so when we think about those things, and I really appreciate that there's some of you all who have worked in multiple settings. And some of you are thinking about, let me put my resume here, and I worked here from this period, and then I worked here, and then I've done some of this. So like Joanne is saying, did some inpatient, some private community hospital, also did residential services. Some people have done CMH, now doing things with treatment and court services. I am curious because I have also worked in these different settings, and I want you to think about how sometimes our roles and boundaries, and maybe even our ethical obligations or ways that that shows up, might shift when you are in these different settings. So for myself, moving from community mental health, even when I moved from community mental health to schools, it was very different. One big thing that I remember is Heinz 57 variety of work experience. I love that. So when I want people to kind of take this journey as you think about even going from community mental health to school social work. When I worked in community mental health, it was very much about person-centered planning. That was a big thing. PCPs. Now, of course, I had to learn once you get into medical settings, PCPs has a different language because we're typically saying primary care physician, but in community mental health, PCP meant person-centered planning. And that meant you thought about people's big goals, right? Their big goals in their words, how they wanted to view their lives. It wasn't what we then learned in school social work that I needed to have a SMART goal that was specific, measurable, attainable, realistic, time-oriented. It was not the same. And then in school social work, it was really about thinking about goals that related to education. Now, I don't know if it's still that way right today, but that is what it was like when I was there. So I had very more formulaic goals and objectives to put in to their treatment plan. Whereas in community mental health, it felt very broad and it felt like the planning process was this dynamic, moving process that really was about where do you want to see yourself? And we want to start there. Whereas school of social work for me felt like there was a lot more. I need to identify what the challenges are, what the current issues are, and what we need to be addressing right now to help with educational success. And then shifting into medical field, it felt much more what is the acute immediate need that we need to address right now, and what supports can I offer right now, and what supports will you need when you leave this setting. And as Jane is saying, in all group settings, clients' needs too often come second to institutional needs and culture. Now, I know this is a webinar, but now I feel like I want to ask people to say more about what they're saying, because these things that you all are saying are really critical. And I'm wondering if others can share any ways that you saw your role or boundary and ethic shift when moving from one setting to another. Amanda, talking about public to non-public, discouraged from doing case management type of work now that you're in private practice, which doesn't necessarily sit well with my framework and morals. Okay, Amanda, you are talking my language, because I actually used to be a home-based clinician. And so when people, even in schools, when they were like, no, the parents need to come in, I said, come in. They live right up the street. I can go right over there. I can get right in my car and go. I don't need to wait for them to come here. I'm used to going to people's homes, from being a home-based clinician to doing school social work and then private practice, and people discouraging you from engaging in that type of work. It doesn't sit well with me either. So what I have needed to do is think about how my clients and I can identify their treatment plan to match what they need. Formulaic. Oh, the word of the day. Let's put that word of the day. Our word of the day is formulaic. Our word of the day. Seeing the difference from CMH and substance use disorders. Yes, and how person-centered changes, even though they're supposed to be in the same system. And I think there has been movement to try to change substance use disorder to still be person-centered, but there are still a lot of programs that are still more punitive and enforcing change. And of course, it depends on where you are. Focus on productivity and the number of client sessions rather than the quality of care. Rebecca, I don't know, do you know why we had to shift to being more productive? What happened to make the shift from care and quality of care to productivity? Does anyone remember what happened? And it may be different from state to state. I think for me, what I realized, money, yes, right, the money. When we move from being, when fee for service has led to having a concrete, this is what we get paid for this is what we get paid for that. And unfortunately, that changed the way service delivery occurred, right? So they wanted to say, we want to see every single thing that you're doing. And we're only going to pay this much for this service. Case management, you will pay this much for this, for case management. We'll pay this much for therapy. We'll pay this much for this. Even though an hour is an hour, it isn't always reimbursed in the same. So thinking about those things is really important for us to recognize. So yes, now, even when you do think about the roles that you play, now some people would argue that if you're moving into more mild to moderate, non-public outpatient services, that your role and boundaries might need to shift, because you are no longer the person responsible. Remember the word responsibility yesterday. Community mental health, public behavioral health services have a different level of responsibility. And so I do want to ask us to think about, are there different roles that we should play if we're acting in the role of a therapist and not a case manager? Should that be reserved for people who are providing community health work? Should that be reserved for people who are providing peer support services? Should those roles be reserved for people who are actually doing case management? And should there be some boundaries to identify what each role does? Now, Garrett is saying yes, and I'm wondering if others have thoughts. And I want us to think of it as being like, all of these questions that I'm posing is not necessarily right or wrong. And as Stacy Peterson has always taught me, is that it's not about the way, it's a way. And so I do think there's things we need to consider, right? What do we consider? So Beth is talking about there's attempted justification for the productivity to focus on, to get clinicians on board. Oh, wow. You get to see more clients and serve more people, and overall have less work if you do it well, or clients get to participate if you type your treatment plan out with the client. But it doesn't actually work on the ground, at least for me. I really appreciate that, Beth. And it sounds like we're going to get into some of those strategies that some people try to say will be helpful and some are not. Yes, it's key because we have to maintain boundaries. And what I like to remind people of is boundaries are important, but if we are centering justice, I do want us to think about when we center justice, sometimes boundaries look a little different. And so boundaries are more about what is realistic, what does each person need, how do we keep each person safe, the clinician and the practitioner, right? To think about all of those things in the moment. So I just wanted to name, there are going to be different things. So for example, in medical social work, especially if you're in the emergency department, your role looks very different than the role of someone providing year-long therapy services with a person individually, one-on-one, for an hour a week. The level of engagement, the type of relationship that you're going to develop, the rapport, it's going to be different. Right. And again, I'll ask for people, please share if there's any ways that you've seen that you've needed to shift your roles and boundaries. And I appreciate someone saying not necessarily ethics. Now, when I say ethics, we know our ethics are our ethics, but there are different considerations that might be made, right? So when we think about our ethical obligation to maintain services for someone, that is an ethical obligation. It talks about in our ethics that we should try to maintain consistency. We shouldn't abandon clients, but there are some settings where the reality is you will see that person one time and you will never see them again, right? So that ethical standard is something we need to consider, but it does look different because what we're doing in that moment is we're being transparent and making sure we're providing informed consent to let them know we're only going to be working together in this specific period of time, so that they know it's not necessarily abandonment, but we're also not continuing to work long term. So when I say ethics shifting, I by no means am trying to insinuate that our ethics go out the window for any of these. We have to keep those grounded, and really we have to keep social justice at the center. All right. So to talk about those things, I want, again, remembering our roles, considering our ethics, no matter what role we're in, let's think about our purpose, right? Our values and ethics. We're trying to apply our social work ethical principles to guide our practice. So what I also encourage people to do is, in addition to thinking about the National Association of Social Work Code of Ethics, to also think about the International Association of Social Work Ethics and Social Work Statement of Principles. Because I think that yesterday people talked about, well, we are working with multiple people from different spaces. Some of you all may even do global social work. So I also encourage us to think about other things. Oh, Elizabeth is raising your hand. Go ahead. Go ahead, Elizabeth. I don't know if you're trying to talk, but okay. I'm gonna, as Elizabeth, if you're able to get in, oh, Elizabeth, you're not able to unmute yourself. So sorry, but if you could put it in the chat, I do see that you have a question, so I'll slow down for a moment. And I'll read what Rebecca shared. Moving into private practice from CMH has allowed me to take the time I feel is right and ethical with my clients and provide them with the systemic care they need in between sessions, like trying to make changes at their school to support them. I just don't get paid for that time now, which can be challenging. So, Rebecca, one of the things that I have encouraged, what I do in my clinic, which is what we're going to talk about as far as strategies for interventions, is what are ways that you can collaborate and partner with your clients so that those could be billable services, and making sure it's a part of their treatment plan. Because, and I know it can only be billable if they are a part of it. And so are there ways that you can, as my colleague calls it, using companionship through that advocacy to be able to do that? Because it is making it difficult for practitioners to do that work when there is no time allotted for it within the framing of fee-for-service work. So I do want us to name that. And again, and so I just want to pause to just see if you can get that thought into the chat. Because I usually, when people raise their hand, it usually means we need to slow it down a little bit. But if you can see, actually, why don't I put those up? I'm going to share what I put in the chat for the International Federation of Social Workers to think about what those principles look like. And so, as you can see, it's very similar. But when we're talking about centering justice, think about human rights and human dignity, the right to self-determination, the right to participation, respect for the person and their community, respect for privacy in family and community life, recognizing strengths. That should sound very familiar for us. Interdependency of people, right? I love this one because it talks about, we talk about the importance of human relationships in our code of ethics. And we want to think about the interdependency of people and supporting these interdependent relationships. Social justice is literally here, challenging discrimination and oppression, respecting diversity in societies, access to equitable resources. So thinking about those principles are really, really beneficial. All right, so we have some questions. The current 12 appointment rule for services at CMH in the service of providing the service the individual requires. Now I am wondering about that. That led to hearing about the 12 appointment expectation 100 times. And Elaine, I usually tell people that if you need to go for a hearing, I think we just need to keep doing it. And Brenda asked, like, gray areas between law and ethics. Are there gray areas between centering justice and ethics? So, and I do not think that there is a gray area to me. I mean, so when we talk about gray, it depends on what you mean by gray. I think that when we center justice, we would need to look at our ethics through that lens, right? So if we look at a ethical standard, for example, and it says, well, you need to, mandatory reporting is one of my favorite ones to use an example, right? So ethics say you must report instances of abuse, neglect, things like that. If that is the case, and we are centering justice, what would that look like? Now, to me, centering justice means we have a world where people are safe, people can trust, people have access to the things that they need, people are a part of the process. People are a part of the process from beginning to end. So if I am centering justice, and I need to file a report because my ethics say I have this obligation, then I would engage with that person to contact whatever reporting mechanism I have to use, and we would do that together. They would be able to share how they are seeing the situation. I would be there to share what my concerns or what my assessment is. And I do that, and I call that co-reporting. Okay. So I think that is one of the ways that I would name how we center justice while still adhering to our ethics, but our ethics should not supersede centering justice because our ethics say that that is our primary role and responsibility. And I don't know if I articulated that well or if someone else has ideas about what Britta is asking. Like, is there this, is there this muddy space between the two? Yes. So if I have to report a parent for suspected abuse, I would invite that same parent in to be in the report call with me. Yes, I would. Yes, I will. Yes, I have. Yes, I always do. The only time I have not included the suspected abuser is if the parent that I'm working with has shared that they suspect someone else is doing something and they don't want to be the person to call on that other person, and then I have made the call. That has been twice, but every other time I always co-report. And I'll tell you, Beth, I'm a alum of foster care, so I was in foster care. I was removed from my home at school. I was at school when we were removed from home. And so ever since I have been a social worker, it has been very critical for me to think, because I don't feel like justice was centered there. Yes, I recognize that people felt that we could have been in danger and it was an emergent situation. I can respect that. And I don't feel like they respected my family enough to reach out and allow my mother to be a part of that process. And I vowed to never do that because that's not justice. It actually created a lot of injustices. So yesterday we talked a lot about thinking about what is our outcome? What is our outcome? What are we trying to see happen on the end? Are we trying to make sure social justice is realized? And making reports without people being present is not going to make that outcome. And yes, Stacey, I also tell people in the beginning about those things, but the way that I share my statement, you all are getting into the strategies. Uh, you know what? That's interesting, Abigail. I think that it depends on who you are talking to with CPS, because the CPS folks I work with, and maybe it's the county that I work with, they have actually advised me to do it. Now, here's another thing that we have to think about centering justice. I want you all to recognize that all of us may have gotten different information in different language. Sometimes it's about, because who are we protecting when we don't talk to parents and families about calling and making a report? Who are we protecting? Who are we protecting when we don't tell the parents or the family or the individuals that we're making ourselves? We're protecting ourselves. So some CPS specialists will say, well, you might be, they might get mad at you. You might be this, you might be that. So, I don't know if you should do that or not. But that is not centering justice. That's centering yourself and your comfort level. And so for me to not have to have a parent yell at me or be upset with me, I'm going to call and then I'll let you know. I just don't, I believe, for me, when I center justice, and Marianne, they may not want, and then I would ask them, are you doing this? Why are you doing this? And is this centering justice? Because when we don't let people know, and actually, now I have to pull up the code of ethics to make sure that people know that a lot of times when I say this, people are like, wow, you do that? I'm like, yeah. And it's actually not really, it's actually not a novel idea. It actually is written explicitly in our code of ethics. And so what we need to, let's see. So we know about informed consent. I have to find it. Is it under confidentiality? Okay. Here, this part talks about Social workers should protect the confidentiality of all information obtained in the course of professional service, except for compelling professional reasons. The general expectations that social workers will keep information confidential does not apply when disclosure is necessary to prevent serious, foreseeable, and imminent harm to a client or others. In all instances, social workers should disclose the least amount of confidential information necessary to achieve the desired purpose. Only information relevant to the purpose for which the disclosure is made should be revealed. Then it says under D, if social workers plan to disclose confidential information, they should, when feasible and to the extent possible, inform clients about the disclosure and the potential consequences prior to disclosing the information. When should we share it with them? What does the code of ethics say? I need to make sure you see this. Let me make sure it's sharing on the screen. Yes, it's sharing on the screen. Prior. So what I'm telling you is nothing, it's literally written in the code of ethics. So what I have been, and you may not necessarily agree with it, but this is what our code of ethics say. And I also want us to think about it through the lens of, again, centering justice. And I welcome if you want to share in the chat. I'm sorry, I can't let you unmute. But I definitely would love to hear what are the disagreements about it. Again, when we think about centering justice, I do want to remind us that we're talking about centering justice, which means that all people have the right to live, to be free, to engage. They have choice, they have all of these things. That's what centering justice looks like. It does say with regards to our professional approach, so I think it is very context specific. I'm not sure I understand, but I also think that so context specific. So no, remember it is definitely saying when to the extent it's possible, which goes back to our thoughts about where our settings are, right? If I have only seen one person, and I don't know their number, I don't know where they are, of course I can't share those things, and I still need to make the report. But if it's someone that I'm working with every week to week, that is not the same situation. And I'm talking about all things. The way that I share my confidentiality statement, I don't say, this is exactly what I say. I say, everything that we talk about is going to be confidential. The only exceptions to that is if I have a concern about the health and wellness and well-being of you or someone else. In those times that I have a concern about the health or well-being or safety of someone else, I will talk to you about those concerns, and as much as possible, we will work together to figure out how we can mitigate those concerns and keep everyone safe and address the concerns that are present. The only time I would do that without you is if you are not able to do so. And I always use the example, I say, and so like, for example, if you pass out on the floor here, I'm not going to ask you, is it okay if I contact 911? No, I'm going to contact 911. So even if someone is experiencing psychosis, if they are still able to comprehend what I'm saying, I'm still going to include them in that process. I'm still going to have them be a part of hospitalization. When I've had to hospitalize people, that I have them do the calls and make the arrangements to go whenever possible. Now, if someone is not cognitively present, not able to make decisions, not able to communicate with me, that is a very different situation. And again, that means to the extent it's possible. But those times have been much fewer in my experience. And the times where I could actually engage the person and work with them has been much more frequent. So, and as you notice, Denica, I'm sorry if I'm pronouncing your name wrong, but that's why I don't just say child abuse and neglect. I don't just say that because it could be an adult, it could be a child, it could be anybody. I don't care what, if I have a concern about the health and safety and well-being of Danica. Okay, thank you. If I have a concern about anyone's health and safety and wellness, I don't even, and I tell clients, I don't have to be mandated to do it. I'm going to do it because that's what I believe in. If I'm concerned about safety and health, I'm going to do something. So that is how I give my confidentiality statement. It is very broad for me. Again, because I think it's not just CPS, it could be adult protective services, it could be hospitalization, it could be a number of things. And that is something that we can think about. Now, Randy, you're bringing up other thoughts about many considerations for including notified parent of CPS, justice for an integrity of parent, safety of child if shared, impact on relationship with and between child and parent. Now, if a youth that is 12, 13 and up share something, I may not contact the parent immediately, but I will do the call with the child. Did I hear someone? Elizabeth, are you able to speak? I thought I heard someone. I'm sorry if I made a mistake. I thought I heard someone. Relationships are everything. And I also want to acknowledge for everyone, I appreciate people thinking about safety of the child, safety of this, safety of that, but I also want to remind you about what centering justice means. And remember, if I can say anything, and some of you may have been in the same experience, so I don't want to say that we might have different experiences. I will say for me, whether the social worker that called Child Protective Services and the Child Protective Services that removed me and my sister from school on that day, they could have had every best intentions. They may have been afraid of what my mom would have done to me when I got home. I do not know, but I know 30 something years later, 40 years, oh my goodness, more than 30 years later, my family is still negatively impacted by that to this day. To this day. So if it could have been changed just by simply including my mother in the call, I think that would have made a big difference, because now we think about the intergenerational impacts of that. What has happened to me and my sister, what has happened to our children, how that has impacted our families. And where is that social worker at? I have no clue. Living their life somewhere while I'm left with the bag to hold. And there's countless stories that say very similar things. So I do ask people to think beyond the things that we kind of put up in our heads, and always center justice, and think about, what would this look like? How can this be the most empowering, engaging experience as possible? And last thing I'll say about that is I will also share that the CPS workers I have talked with have also appreciated me doing that, because they also said it reduces the danger for them of going out to homes unannounced. So for me, that is a win-win, because when a parent has someone come out unexpected, the Child Protective Services workers are coming out, if they come out unannounced and the person doesn't know, yeah, that might mean they get to catch them. But is that centering justice, trying to get them to get caught? Or like, what are we doing for that? So I just encourage us to think about, what does centering justice really mean about that? Yeah, people are afraid to take their kids to the hospital when they get hurt, for sure, because they're afraid of what could happen. And then children don't get the care that they need. So thank you, Stacey, for putting those things in. I'll recommend looking into mandatory supporting. Oh, I love that framework from JMAC for families. That's your I'll have to find what that is. Yeah, also I have to talk about dangerous practices like drug abuse. We can bring up all those things in our concerns, but I love this mandatory supporting framework, and that centering justice. Like, we need to focus on that. So But keep going, because again, when we talk about using the social justice lens, just want to make sure we are thinking about our code of ethics and what it says. A lot of the things that we have come up against are really not what our code of ethics say, right? It talks about focusing on individual well-being in a social context and well-being of society. Fundamental to social work is attention to the environmental forces that create, contribute to, and address problems in living. So our primary mission is to enhance human well-being, right? With that, we talked about this yesterday. So we talk about in private practice, what does this mean? It means our role is to kind of think about, how do we support this primary mission? How can we do those things? Now let's get a poll in to see if you all are listening and make sure everyone is here. Now, because some people think about this and they say, I've been talking about the code of ethics and the things that you're responsible to do. So the next poll is, if you are a macro social worker, you don't have to use the NASW code of ethics to guide your practice. True or false? False, false. Thank you, Sonia. False, false, false. So even though we can talk about, we have different settings, we have different responsibilities, at the end of the day, no matter what type of social work you're practicing, you are still responsible for using the NASW Code of Ethics to guide our practice. And so again, when I tell people, actually, you're supposed to share with people before you break their confidentiality and let them know what could happen, people should know, right? We need to think about that. Abigail, don't faint, don't faint, don't faint, don't faint on us. I want to make sure we're in that place. Thank you all. So I'm going, Elaine, that's okay. We got it. We got it. We know. We all know that that is false. So some of my colleagues on here that are educators are going to know that I have borrowed these inclusive / equity focused practices from the Center for Research on Learning and Teaching. I am someone that does not like to recreate the wheel. And when something feels good, it just feels good. And I think we can apply it to a number of different things. So even in teaching settings, when they're talking to us about how can we create spaces that are equity focused, that puts equity in the center, what are some core components of that? And some of you may have seen this: transparency, belonging, critically engaging difference, structured interactions, and flexibility. Okay, those are these 5 core practices, principles that you can incorporate whenever you are trying to center justice. Now, as you see, and Janice, thank you for acknowledging the story that I shared, because if we can think about even using these equity-based principles in a situation like that, I'm asking people, they should have been transparent with me, my sister, my mother, my whole family. When you do things like remove people from school, does that increase a sense of belonging? No. And I'm the child. I was removed, right? I didn't get to go home. That doesn't increase a sense of belonging. They also weren't critically engaging difference. They could have critically engaged difference. They could have created a sense of belonging. They could have invited my mother into the school, let her know she's a part of the community, that they care about the safety and well-being of all of us, right? And ask them what could help with this and give her an opportunity to engage. Structured interactions. Structured interactions means that if you co-report with someone, they know exactly what's about to happen. You're sitting with them, and it's not just someone coming into your home or coming to you telling you the allegations when you're not even ready. So I want you to think about, I've been asking you all questions all day. What about the people that haven't been ready? What about the people that's like, I still need to think about that question, and you're on to the next slide? That's not we got to have different ways for us to interact. So that's why I try to have like some free write, and we try to have a little bit of all of those things. And lastly, flexibility. We need to be flexible. It doesn't mean we just have to do things one way. That's the only way. If the parent can't come in, then we can't engage them. Well, now we have telehealth, we have cell phones, we got what's the thing called FaceTime, all of those things that we can do to be flexible, and it doesn't have to happen and occur in one way. Thank you. So I'm going to share some thoughts, right? And so when we think about our profession, now I know everyone here may not be a social worker, and that is okay. But if you are a social worker, I want us to just like key in on what are the things that set our profession apart from our colleagues in other helping professions. And these are the things that we're talking about: the intimate and complex connection between individual suffering and social context, the environmental correlations and determinants of human suffering, the long-term solution happens in political and policy arenas. So we're thinking about all of those things as well as what's happening to the individual. And a big example that I saw that in was with COVID-19 and telehealth. So, how many of you all did telehealth prior to COVID-19? If you did telehealth prior to COVID-19, just put a yes in the chat. If you didn't know, if you didn't, put no. Only after, only after. Oh, so Cynthia, we have a couple that did, but a lot of people had not been utilizing it. And I had to utilize it prior to, and some of you might be in rural areas. So if you're in a rural area, you might have had to use it. But even working in a, I work in an urban community. And one of the reasons we started looking at policies and procedures for telehealth was not because of COVID. It actually was because of the number of trans-identified folks that we worked with that were having so many barriers and so much distress traveling to the office to be seen, and the experiences that they were having by being misgendered and people harassment, discrimination, prejudices just to get to their appointment. So when we first started looking into telehealth policies and procedures, it was actually not because of COVID-19, but then we were well primed to be ready. And before COVID-19, a lot of you may not know, most insurance companies did not even say you couldn't do it. There were no reasons why we couldn't. People just didn't do it. They just didn't offer it. So Elizabeth, actually, they act, well, I'll say in Michigan, our insurance, we're a CARF accredited organization. And in Michigan, the insurance providers, only one had a clause that said telehealth services could not be reimbursed. All of the others actually could. Now, post-COVID, they are trying to restrict it. But before COVID, they didn't even have, they didn't say you couldn't or you could. So for me, I like to ask forgiveness instead of permission, but only one of our providers. Okay, in New Jersey, they might have already had that in. So in Michigan, our providers, because we had done the research to find out, can we do something different? And we could. So again, thinking about centering justice. We want to think about developing fully. So let's move forward so we can get into these practice strategies and thinking about it through our competencies. Oh, yeah. Okay. So Julie, you had the people had it in a plan. So people were planning for it and talking about what it meant already. Thank you for sharing that. So what I'm going to share with you is to think about the competencies. And I do want to just say one more time for the telehealth thing. So it's helpful to hear like in New Jersey, because I think in Michigan, because we have so many rural communities as well, telehealth really, it wasn't new because people had to do it because there weren't enough providers in certain communities. So if you're in certain communities or if you work in certain settings, especially rural spaces, telehealth has actually been up and running for a very long time. And because it had to, some hospitals, they couldn't get psychiatry. And so it just looked different because sometimes people were telehealthing into the site, right? Like they had to have a psychiatrist from another place telehealth in, and the person was seeing them in the office. So just to kind of note those things. And I note those because sometimes we can feel like things are impossible to do, and it really isn't impossible. We just have to do the research to think about how we can advocate for different things to occur. So I'm going to ask you to think about practice strategies using our core competencies: engagement, assessment, targeting goals, planning, intervening, and evaluation. So I like to call that's when we eat pie. Okay, so if you can remember how to eat pie, you'll be able to think about some of these strategies based on each area of competency. Okay, so let's start with engagement. And I also welcome people to chat to everyone things that you do that you think center justice for each of these competencies if I'm not listing it. Okay. So with engagement at the micro level, I encourage people to think about making sure there's transparency in the availability and ways to access services. Technically, we should have been sharing with people that technically, if we do a person-centered plan, they should be able to access their services at home, in the community, on telehealth, or in person, because those are things that are real. If it works best for them, that's what can work. Or just share what you're able to do. If you're not able to do this, what you need to be very clear and transparent about how they access certain things. Share the difference between using insurance and not using insurance. Even though the clinic I work in accepts insurance, I still share with people what are the pros and cons of using their insurance and not using their insurance. I work with mostly everyone I work with has some marginalized identity. Many of you probably do too. And so I have learned that having certain diagnoses through your insurance payer often has long-term repercussions for things like your life insurance premium. I need Black folks to know that. I need trans folks to know that. I need people who have low socioeconomic statuses to know that. Certain diagnoses can preclude you from going to getting certain jobs and getting certain clearances. People need to know that, and they also need to know that, yeah, we say it's confidential, but if their insurance has the billing code and they go for a job and they sign a release of information, everyone can see what they were treated for, right? It's invasive. So I try to be very clear. Yes, you can use your insurance. This is what it's going to do. This is who will be able to access it. If you don't use insurance, this is what this looks like. These are the pros, these are the cons. Also describe your practice philosophy and ensure that clients can choose the provider they would like to work with. I'm not a big fan of people calling and just getting assigned to the next therapist. That doesn't increase choice, that doesn't center justice in the way that it could. And asking real questions when you're talking with people and engaging with them instead of just like, how are you? Because most people are going to say good, right? So, yeah, and why veterans who don't choose to go to the VA, that's one of the reasons why. So are there any engagement strategies that you all use during the engagement process outside of sharing your philosophy, letting people choose who they want to work with? Anything that I haven't mentioned, please put it in the chat to everyone. If you're in a macro setting and you're thinking about engagement, maybe you're the clinic owner or thinking about managing some of these things, meet with the community stakeholders, meet with the board of CMH, schools, universities, the consumer advisory groups, primary care physicians, go to the dentist office, all of those places, learn about their efforts. What are they doing? Connect with each other, participate in community activities, be willing to host a table talk at fairs, meet with potential practitioners that are currently in training. So connecting with those universities again. Get to know yourself again. Get to know yourself again, because the person that we are today is not even a person that we were yesterday. So taking time to write your personal philosophy statement or revising that is also something that we would encourage you to do. Letting people know that therapeutic alliance is important. Oh, thank you. I'm going to give you another example of how I do that. If a person reaches out to me to engage, and asks me, and say, oh, I want to talk to you. I think I want to use you as a therapist. I say, let me tell you my approach. Let me hear what you're looking for. I actually never set the appointment right then. I ask them to think about everything that they've heard and to reach back out if they would like to schedule an initial session. Because I feel that I have realized, and it has worked for me. I realize that a lot of times people are feeling like, well, I'm talking to you now, it feels okay. But I don't want them to feel like they're obligated to make an appointment with me in that moment. So I always ask them to step back, think about all that I've shared. If they have other questions, they can ask me before we move forward, because it is like therapy is like finding a good therapist, like finding a good pair of jeans. Sometimes you got to try things on, right? So writing your current story. So for me, it is about, I reshift the way that I practice a lot of times. So like right now, my philosophy statement has had to change to really incorporate how I want to be restorative in my work, so that clients understand that when they come to me, I'm not going to be the person to say, cut your family off, forget those people, they're toxic, because that's not how I operate. I use a restorative framework now because it aligns with African-centered principles. And so I have to rewrite my personal philosophy and narrative to ground me in who I am at this moment. Okay. So yes, and definitely being in those spaces. Share their boundaries. So then going into assessment. Okay, Emily, thank you. And that's a part, sharing your boundaries, when you're off, how they can reach you. All of those things are being transparent, right? Being transparent with people. That's all that matters. It's not that one person's is right or wrong. It's just being transparent about it. In assessment, making sure when we're centering justice, you want to make sure all paperwork is accessible in multiple ways. Try to make sure you can access it electronically, hard copy, and also allow, if people want to complete it with you, allow that to happen. Provide options for screenings to be completed prior to the first appointment, so people have the privacy if they want to do it, or so that it doesn't take up the time. Offer support for completing forms. Provide different methods of interaction to complete the assessment. Can people provide their own personal description and narrative? Do they want to write it out for them? Can you just give them a form and say, how would you answer these questions? Or should we do it in a storytelling format? Like, tell me the story of your life. Focus on the strengths. Share the purpose of the assessment. Why are you even doing this? Is it to get to know them? Is it to find out more about their symptoms? Is it to help you with their treatment? It should be all of the above, of course, but you need to tell people that, because remember, many people are not trained in this. So you need to tell them, what is the purpose of this? Why am I doing this? Will there be a diagnosis from it, and why? If you hear, so many people don't even know they have a diagnosis. They don't even know that people are asking them questions to formulate a diagnosis, and that just is not fair. It's not fair. It's not centering justice when we assume people know those things, right? And so making sure you are sharing those things. Why do they need a diagnosis? You got to think about that. Identify the strengths and identify needs, and consider, do I need this paper or computer? Why do you need to have a piece of paper in front of you? Do you need to have that computer in front of you? I recognize that all of us have different accommodations that we might need. And if you do need it, then you need to share why, right? Elizabeth, I actually would believe it, because I think that most people I've worked with have never, they are surprised when they hear what their diagnosis is. And they're like, this is what they told me. I'm not sure. And Amanda, thank you for naming that. Clear as kind, right? And some people are so afraid to have the conversation with people. And it's like, if we can say it and write it down, we should be able to do it with them, because that's respect, dignity, and respect. If you're thinking about it from a macro lens, do a community assessment. Again, making sure you're focusing on the strengths. and the things that they identify as common challenges. Learn about the current resources available and think about what are different partnerships. Because in private practice, you typically won't have all of the things that like a community mental health has. So you have to think about how do we partner with these other people for the things that people need. Develop tools that are user friendly and focus on what is needed to know. Go through some places have 10 pages of stuff that is like, what do we need this for? Right? What are we asking these questions for? Is this something that is needed or not? Go back and review those things. Develop policies and procedures that focus on the engagement during an assessment. When people are saying, oh, you have to have this full assessment completed by this time, and it's 10, 20 pages, and have it done the first session, that's not focusing on engagement. That's not focusing on engagement. That's not developing a rapport. That's not centering justice. That's centering the need, your need, and the needs of institutions, right? So yes, that's another thing. I might even offer, where would you like to do the assessment? Would you like to walk? With young people, walking side by side and hearing them share their story actually helps them share and open up and actually even recall things in a better way. So they're actually going to be better historians if you're walking and talking side by side. That's been my experience anyway. If you are a macro person more on the employment side, think about it, identify the strengths of current and future employees. What do you need in your space as a manager to make sure you have different perspectives while also recognizing how people fit within the current culture and climate? There are different cultures and climates, and that difference is amazing. So everybody's clinic should not be looking the same because there's different needs that clinicians have, there's different needs that clients have. And so doing that as an assessment, taking the time to really assess who's coming in and who's going out is really important. As a manager or leader or macro work, think about what are your strengths and opportunities to grow. And think about what are populations and methods that you're most competent in. So as you see, if you're paying attention to how we're going with this, when we're talking about micro and macro, actually we all do macro because some of the macro pieces are what you need to do for you, whereas the micro pieces might be things that you need to do it with someone else. So you still need to be assessing yourself. Who do I work well with? I thought that I would work well. When I first started in private practice, I thought I would work very well with Black women. Do you all think I was good? Well, if you say yes, the answer is no. What what I found is that I actually work best with masculine identified folks. I never would have thought that, but that's what happens when you start to do a self-assessment. You start to look at yourself and saying like, what am I good at? How do I work? Who might best work with me? And sometimes you may come up with one answer and then your clientele and your population will give you another answer. And so my new answer is I work best with masculine identified folks. So then we move into targeting the goals. For the micro level, we want to think about what are their desired outcomes, right? So someone said earlier, even when you come into private practice, you still do not want to lose the person-centered planning aspect that community mental health has offered you, right? So a lot of the things, even though there's some things that are much to be desired in community mental health, I will say that knowing the person-centered planning process has been so pivotal in my career because it has allowed me to really center the person and really take time to think about what do you want to do? What will this look like? How will you know when your goals are accomplished? How will we be able to determine when the current level of care is no longer needed or no longer appropriate? And still using their language and understanding to create those goals. If you think about in a macro space, make sure you're creating planning documents that offer the opportunity to offer large, broad goals and those specific objectives. Like, I don't know why we don't do that anymore. But I I really wish we always had a space of like, what is your big goal? Because that's the thing that sticks out. Your SMART goal is not necessarily the thing that keeps you going. That large, like, what am I working towards is the thing we can do. And so at the macro level, you also want to think about developing professional development goals for planning for your staff. And then for yourself as practitioners at a macro level, you need to target your goals about how much money you need to earn. I have to put it in there. And for some of you all who are minimalists, that number may be smaller than some of us who are not. So really having an idea of what do I need to earn to live can be a starting point. A lot of times people just say, I want to earn X amount of dollars without even doing a real assessment and analysis to say, is this really what I need? Is this what I need? And how will I know that? So doing that. And then moving into plan. I know I'm moving faster, but want to get these strategies out and still welcoming people to enter. If I'm missing something that you think you do or have seen done that centers justice, please add them. And I really appreciate, like Brenda mentioned, a friend had a therapist in the counseling program without checking in with goals and he felt bad. Yeah. So when we talk about when we don't check in with those things, it can be difficult. So we want to come in with the goals and then create a plan, right? And then when we're centering justice in this setting, we're going to clearly identify the roles and responsibilities of each person. Now, for some of you, I just may feel like, this is what I do all the time. You're not telling me anything new. But for some of us, I have realized that when we're in private practice, oftentimes we neglect to remember. So we just think that everybody understands the process. So we just keep going and not necessarily thinking about it again through the lens of centering justice. Clearly know those roles are identified, making sure you include supports and other resources. That has been a huge issue in private practice. People very much focus on the person who walked through the door and don't think about other people. Yes, people don't realize they have the option to have the client support person present if desired. I tell people I have actually never had a client that I haven't had at least one person in their life participate in at least one session. That's from kids all the way up. It can be their friends. It can it could be their family, their parents, their sibling, anyone, and we found that it makes it a lot more manageable, even for me as a clinician. Remember in the international, I just showed you that we think about that interdependence of people. And sometimes private practice can be very, very narrow and very individualistic. So I wanted to remind you all that through this planning process, to make sure you're including these things, acknowledging if there's other services they might be eligible for example, in community mental health, and ensure that strengths are used to support meeting the goals. It needs to be named. This is a strength of yours, so we can use this to do this. And also planning in the moment for planning for challenges like missed appointments. Because when we don't do that, what often happens in private practice is that people will get frustrated with a client who, as people say, no call, no show, or miss appointments or are late, and then they're frustrated. And I've actually heard, I don't know, I've heard many people say they've been fired by their therapist for missing appointments. And they had no idea that that was happening. And there wasn't a plan in place for what to do. Now, I have realized that for some clients, missing appointments is actually a sign that their mental health is declining. And so by putting that in a planning process and saying, if you don't attend an appointment, what should I do? At what point should we call in other supports? At what point should I contact your emergency contact person? What should we do about that? Right? If we see that you're missing frequent appointments, is that something that we need to put in your plan about how to make sure you're reserving space for yourself? Can that be a goal that we can work towards? Right? And that has been something that I've been able to do, and it has worked really well. And revisiting it quarterly prior to making any changes. Now, I say that to the clients I work with, I say, well, we're going to try to at least see how things are going for this quarter, because I believe it takes time to see if something is actually working or not. You can't say, oh, I did it that one time, I didn't like it, sometimes things you don't like are actually really beneficial and can actually be effective. So for the macro side, think about professional development plan that identifies the roles of everyone. Again, kind of the same things. The things that is different in this one is thinking about the number of clients you need to see and the reimbursement rates that you can accept. How many pro bono and uninsured spaces can you hold? Right? Because again, if you believe that everyone deserves this amazing type of service, what are the ways that we protect ourselves by seeing how many of these spots do I hold, can I have open? And that was something that I needed to do when coming into this work, is thinking, what is the average reimbursement rate? How many do I want or need from this? How many people can I see whether they can pay or not? Oh yeah, actually checking for the day and time when people are meeting. And that goes back to that plan. When will we sit and think about, oh, do we need to revisit this? Does this day and time actually work for you? I know you said you thought it could, but does it really? So then when it comes to interventions, I would encourage you to think about making sure you expand your modalities and utilize culturally responsive things. So finding ways to adapt different modalities based on the population that you're working with, making sure that you engage community resources and include that as a part of the intervention strategies. Don't treat people as a bubble. Again, include examination of their social identities as a part of the intervention. For example, using a social identity wheel. Is there anyone, I feel like I'm talking so much today and I don't like it, but is there anyone that has used social identity wheels with their clients and had them fill it out and talk about their social identities and how they feel about them, what's important to them? Mostly queer clients. Okay, let me put it in the chat. There is, and put it up on, I'll also just put it up on the screen. So social identity wheels help people to think about how they identify. And the one part about the wheel that I use is it asks them to think about what identities they think about most, which identities they think about least, what identities they would like to learn more about, and incorporating that into our sessions and times as an intervention of kind of like getting to know self, and supporting the individual and seeing those things. So let me open it just to show people what it looks like. This is a social identity wheel. Once you see it, you probably have seen it, but it asks them, Juliet, so I use it in my courses, but I also use it with my clients. And I have found that, ironically enough, because when I'm working with people individually, it allows us to work really, really closely in how they identify themselves and what they think about it. And it has just been, what I do is I use it across the time, and we'll use different, because especially for young people, the way they define or describe their identities often change throughout time. Right. So I'll sit back and think about what are you thinking about most right now? Right. What are you thinking about least right now? Because that also changes based on where they are at in their life at the moment. Okay. So just want to, I do have a link to my Google Drive, and we'll share it out as well. So thinking about that, making sure that you also include advocacy as a part of the strategies for clients, right? So a lot of times people, going back to someone said earlier about how challenging it has been to like advocate or do other things when you're not reimbursed for it. And so oftentimes, so for example, I had a mother who was start expecting, and a Black woman who was expecting a child, and they were like, well, I want to know, I want to find out how I can use a doula. And this was before Medicaid in Michigan had approved doula services through Medicaid. And so one of the interventions that we used was them writing a letter of support and advocacy on behalf of themselves. And we talked about it together during sessions. We talked about why it was important to them, talked about some of the social justice issues that were relevant. And she wrote this letter to and signed on to some petitions for Medicaid to accept to be able to be used for doula services. So they were actually and by the time they had the baby, it actually was approved. So that was like, I mean, it doesn't always happen in a perfect way like that, but that is one way that we incorporated it into their treatment. So I have a question up here that is about non-public clinics requiring a specific number of clients of hours per week. Does it benefit the clients or clinician, or is it simply about the money? My personal thought about non-public clinics that require a certain amount is because they're trying to make a certain amount, which is very different than what I'm proposing, where individual clinicians identify how much you need to make, right? Because I know what I need to make to live. And if I don't need to see 25 clients, why would I? I mean, if I wanted to, I could, but if I don't feel like that's what I need, I wouldn't want to work in a clinic that requires me to have a specific number. Because anytime you start putting in numbers, and I know we talked about this yesterday, it can be semantics, but once you introduce to someone, you have to do this amount every week, it changes the way that it can change. I should say that. It can change the way that you perceive your work and engagement with clients. It can then move away from, am I doing my best work, to, am I meeting the needs or expectations of my employer? Because you're a human being. We're human beings, and humans are impacted by our environment. So if the environment is pushing us to say, you have to do this or you have to do that, human behavior is to try to meet that. So if we can limit that, and to me, that's supposed to be the flexibility of, I would not go into private practice to have the same requirements as any other space. For me, that is why I like to, because I believe it is a space that we can actually center justice. And if we're moving away from that, I don't know if that's helpful. And remember, centering justice is for clients and for us. Because we are clients in different settings too. And then, of course, finally, we want to think about evaluating, making sure your evaluation efforts include qualitative and quantitative methods to think about what did they like, what did they not like. So what was the services like? Collaboratively identify what's working best and how it can be altered. So a lot of people push back on me. I typically don't do the clinic I work in does anonymous surveys that consumers can submit, but on my quarterly, just kind of review, how are things going, what's going well, what's not going well. I don't do that in anonymous format. And I tell my clients why, because I'm transparent, because I believe it is important for them to learn how to share with people how they feel, negative or otherwise, unapologetically. That is a skill that a lot of the people I work with need to learn, how to communicate things. When I'm working with children, I don't want children to think that they can't say things to adults. I want them to learn how to communicate how they feel with adults, no matter what the positionality is. Because when I center justice, in my imagine the world I dream, kids can say what they want to people and be heard. Okay. So I think that is something that I would consider. Well, Beth, I actually think that as long as we are constrained by policies and procedures of insurance companies and other spaces, I don't really think you can work anywhere, unless you're a part of a co-op. That I have to talk about that later. I think in my mind, I could already develop what this cooperative, community-based, therapeutic setting where people are sharing services for services. It's not about money. It's not about capitalism. That we would have to tear the whole system down. But any of the systems that we work in are always there's going to be something about it. And so I encourage us to continue to envision a world without. I see we have Alicia on the line. Ms. Nguyen, I know that you have thought about some of these community-based ways of collaboration that don't lean on systems and structures. So you might think about that too. And yes, and making sure we have these consumer boards in place. That is something that can be helpful. Yeah, and so when we talk about paying clinician, well, that's a whole nother topic, because no, if you people can only pay based on what we get reimbursed, and if we don't get reimbursed adequately, it starts there. But we could go, well, that's a whole big circle. So doing what we can when we can and continue to advocate. And so at the macro level, doing those things and constantly asking yourself, have my efforts impact the realization of justice? And continue to revise as needed. Okay. Other strategies that I encourage you to think about: develop a network of other clinicians, schedule meetings where you all are holding this time, have open dialogue about some of these uncomfortable issues that are coming up. Don't be competitive with other groups. It's enough to go around. It's enough. It's enough. We saw how we don't have to compete with each other. Participate in various insurance coverages, including Medicaid. There are some people that argue that being the most social justice oriented means only doing cash for service, because then you don't have to deal with those systems. I think that is one benefit of it, but then that does remove all of the people that need to use their insurance for coverage. So I think there's a balance of that, and also having both, a both and. So whenever you're using these tools and strategies, as we were reminded by Noah earlier, don't forget to think about, you still have to consider meaning, the context in which you're in, the power differentials, the history of you and the person you're working with, and never, ever, ever, ever forget about the possibilities, ever. Okay. And we have one last question for you all, and that is, which of the following strategies would best center justice in outpatient settings? Requiring all clients to have a state-issued driver's license, providing philosophy statements for all clinicians for clients to learn about the clinician prior to scheduling an appointment, or utilizing DSM codes based on reimbursement ability. That would be the correct answer is B. Oh, did I skip something I wanted to make sure I said? Making sure, because one of the things I also talk, oh, yes, in the intervention for macro, I got to say this, and I know I only have 1 minute. Advocate for policy changes with DSM requirements. Like, what about the Z codes? Why won't they reimburse us for that? Reimbursement rates and collaborative care rates. That's what we need to do at the macro level, because there's so many different DSM codes we could be using, but we don't, because of what the insurance providers, and the insurance providers should not be directing our assessment and care of people. That should not be. Most people most accurately align with the Z codes. So I did want to, I'm sorry I missed that. But don't forget the possibility. Yes, that is correct. We'll share this with resources, and whew, I'm done. That is it, taking over. You all we made it to 11:30. Most people did get the B. You all are great. Thank you so very much. Thank you for joining us. I'm sorry this probably felt a little less interactive, because it was more trying to get the strategies out and sharing those things. But I thank you all so very much.
Well, Dr. Price, we thank you so very much for this wonderful presentation, and thank you to everyone for attending this session of the Building Healthy Strong Communities Conference. We hope to see you at another session this afternoon. The next session, titled Trauma-Informed Programs and Practices for Schools, a Research-Based Model for Systems Change, will take place today at 1 p.m. Eastern. In the next 1 to 2 weeks, those who have met the attendance requirements will receive an email from our continuing education office. Any questions regarding CE should be directed to ssw.coned@umich.edu, and that email is on the screen right now. We thank you for attending and have a wonderful day.